Hello, I'm Thales Gomes, and I'm a second-year internal medicine resident at the Western Michigan University, and today I'll be presenting a case of post-traumatic pulmonary herniation, an uncommon cause of chest pain. Beginning with our case description, we have a 56-year-old Caucasian male with a history of COPD, crack cocaine, as well as cigarette smoking, as well as obesity, who presented to the hospital due to left-sided lateral chest wall tenderness after a fall. His physical examination was significant for wheezing, as well as significant tenderness to palpation of the left kind of anterolateral aspect of his thoracic wall, where we could also feel a protruding mass on the same region. And there was also visible ecchymosis extending from his left-sided chest wall into his left flank. So today I'll be presenting a case of traumatic lung herniation secondary to a fall. The initial evaluation with a chest x-ray wasn't remarkable. A CT of the chest was performed and it showed some infiltrates, atelectasis, and a small left-sided pleural effusion, as well as an intercostal widening with mild pulmonary herniation of the left lung base. CT of the abdomen and pelvis showed some left flank contusion. The patient was admitted to the hospital and started on antibiotics and steroids due to concurrent community-acquired pneumonia and COPD exacerbation. Once we identified the lung herniation, we consulted cardiothoracic surgery, who did not recommend surgical intervention. We also discussed the case with anesthesiology for possible nerve block due to significant pain. However, they did not recommend that, as it would be only a short-term solution for the pain, and they recommended multimodal therapies including opioids, acetaminophen, lidocaine patch, as well as topical NSAIDs. Here we have figure 1 showing an axial view with a defect between ribs 8 and 9 and some lung tissue protruding through that defect, characterizing the lung herniation. Here we have a short video of the same defect just to show the extent of it. And then we have a coronal view now showing the herniation between ribs 8 and 9. And here we have a short video of the same thing on the coronal view. Moving on to our discussion, lung hernias are rare. We only identified around 300 cases reported in the literature. As far as etiology, they can be either acquired or congenital. The acquired hernias can be further subdivided into traumatic, which is the most common type, pathologic, or spontaneous. Conditions that increase intrathoracic pressure, such as vigorous coughing, sneezing, heavy lifting, and playing instruments, have been implicated as the inciting events, and comorbid conditions such as smoking, obesity, male sex, COPD, as well as other pulmonary diseases have been implicated as risk factors for the development of lung herniation. CT of the chest is the diagnostic modality of choice because it can both identify the defect as well as provide some surgical planning if that's the management of choice. Which brings us to the management, which can be either performed surgically or conservatively, the choice being based on the severity of symptoms, size of herniation, as well as other comorbid conditions that would make surgical procedure high risk. The conservative approach basically involves analgesia, cough suppressants, and incentive spirometry. The idea behind that being to allow for full lung expansion and prevent atelectasis that would make the patient prone to developing pneumonia as well. Some people also recommend the use of compression with binders or pads. The long-term prognosis is good. There can be recurrence. However, it is rare, and both surgical or conservative managements have been associated with good outcomes. Approaching the end here with our learning points and conclusion. Lung hernias are a rare condition and therefore they can be initially missed. On the initial radiology report, they did not include the diagnosis of a lung herniation. However, when our team was independently reviewing the images, we saw it and we spoke to the on-call radiology who agreed with the diagnosis and recommended consulting cardiothoracic surgery. The mainstay of conservative management involves pain control, the idea behind that being allowing for adequate lung expansion, preventing atelectasis, and possibly infection. Most cases reported in the literature were managed surgically. However, conservative management should be considered for patients with low-risk features on imaging, such as absence of strangulation or incarceration.